This is the story of Lori, part 2. Some notes for you doctors. Doctor, if you haven't seen the story of Lori, part 1, please go to our website, drchrisbaker.com, and watch it. This second video, part 2, will give you more information of the details and science of this procedure, which can even be seemingly and actually miraculous for a tooth that has signs and symptoms of irreversible pulpitis. Yes, I said it. Conventional wisdom, and what most of you have learned, says diagnosis of irreversible pulpitis is rather absolute, like hot sensitivity, irreversible, lucency, irreversible, etc. And yet, I go on. I have treated several patients' teeth this way that had radiographic lucency and several with hot sensitivity, so it can work, yes. Caries control with IRM, intermediate restorative material, can be coupled with appropriate antibiotics if needed during that first 7 to 10 days after your patient presents, because antibiotic here can be very effective, augmentin or other, to support the body in bacterial lysis. Though I do work hard to avoid antibiotics whenever possible due to the negative effects on the gut microbiome and interactive negativity with other medications such as birth control drugs, and of course ultimate antibiotic efficacy long-term in their life. Still, yes, it has worked well in diagnosable irreversible pulpitis. The body is really amazing when given some support toward healing, and I love avoiding the amputation of the vital pulp for the patient. Again, even in adult patients, have we seen great success with this procedure, which is heartening. Of course, every single patient or parent has an informed consent given to them with explanation, both written and verbal in my hands, that this procedure may be successful and the decision to try it theirs. We cannot stress the critical nature of your information so the patient or parent can make really good decisions for themselves. Let's talk about number 1, children in transitional dentition. How would this work with a 6-year-old or a 10-year-old? First answer, very well. Second answer, whether open apices or not, and this is interesting, the developing molar with pulpitis, whose symptoms fit our diagnostic criteria, has an excellent chance of resolving even quicker than an adult, of course. If your treatment is excellent, focusing on the following. Let's talk about what your focus is. Putting your IRM with immediate proximity of the eugenol in the IRM to the dental tissues closest to the pulp. Removing all carious enamel and removing all carious dentin except any that endangers pulp exposure. We don't want an exposure. Excellent cover, marginal closure at all margins through banding, excellent IRM margins, and finally elimination of all heavy occlusal forces, use of a bedtime splint like a Carney-Baker splint or whatever if necessary. If there's not enough tooth structure to sustain IRM filling integrity over the 8 to 9 months that we're going to leave it there, even with a plain band, a permanent tooth stainless steel crown should be utilized with temporary cement. Okay, let's talk about, secondly, number 2, your fee for caries control. It's a good business decision. The caries control procedure fee in my office, including a banding, is about $500. That is appropriate for the time and office costs spent with and for the patient, which is how my fees are determined. If you need an insurance code, the ADA code for these protective restorations is D2940, CPT code, and we will talk about a few details of that code in just a few minutes. The emergency exam fee is separate, of course, as are the appropriate radiographs, pulp vitality testing if you wish, or other appropriate diagnostic measures, though I don't rely on EPT much here. The caries control fee in my hands also includes contacts with the patient post-op, text or phone, and if you deem the patient or you to require a follow-up visit for evaluation of reassurance, whatever they need, that is included in my office. Obviously, if my patient's pulpal progress were to indicate a possible failed prognosis, I would schedule then a reevaluation visit, and charges would be made as appropriate for treatment needed. A note here, since I've not had that situation in this procedure in all the years, and this is 30 plus, and this is what I realize is so rare, I will tell you that if there might be a need for pulpotomy, referral to endo, etc., charges could then be made for needed treatments. I just haven't ever had to do it. So future definitive restorative treatment of the caries control treated tooth is charged by procedure, of course, at the point that everything looks good. For example, core buildup if needed, restoration as needed from filling to crown. It will not be a non-vital tooth, so you may not need a crown depending on the size of the tooth loss. Let's talk about number 3. What about using glass ionomer instead of IRM? First, glass ionomer for an inflamed pulp? No, just no. Here's why. Glass ionomer restorative and cementing materials are based on a reaction of silicate glass powder, calcium aluminofluorosilicate glass, believe it or not, and polyacrylic acid, an ionomer. The reaction produces a powdered cement of glass particles surrounded by a matrix of fluoride elements and then is known chemically as glass polyalkanoate. Now, so be it, but let me share with you some 4 studies on glass ionomer acidity and pulpal response so that you'll understand why I say no. The initial acidity, giving a prolonged pH at below 3, which by the way is close to battery acid pH, seriously, coupled with cytotoxicity of other ingredients, may lead to damaging effects on the pulp, obviously, when the material in tooth preparation and cementation procedures are less than ideal, or the pulp response is less than ideal. I will put the links to or at least the names of the articles, how about at the end of the video for you. Another one, recent findings regarding pulp sensitivity to eluting glass ionomer cements have aroused controversy as to why there's a problem of sensitivity. And I will link that or give you the article at the end here. It is considered that acid release from the surface of glass ionomer, the polyalkanoate, or alkanoate, however it's said, cements, may be associated with early pulpal sensitivity. That's my whole point. And that, again, is a 3rd article. And finally, another one, composite and glass ionomers in the oral environment are characterized by a low pH that can irritate the pulp. And that's our 4th and final article summary. So these articles are showing us that low pH of the glass ionomer is extremely potentially damaging to the pulp, particularly causing sensitivity, which is telling us something, inflammation. And doctor, think about this. Glass ionomer releases fluoride. Great, you say, but how do you reckon that fluoride gets out? I will tell you, by the marginal breakdown of glass ionomer. So use IRM with a band, a very sedative material whose eugenol helps to heal the tooth seriously. This is love and dentistry. Now, here's what's interesting about insurance. Let's go back to that. I do not work with insurance in my free market dental practice, haven't for about 15 years. Insurance is collaboration, seems like collusion to me actually, between the insurance company, usually the employer of the patient, and the patient, with you in the middle. So it's like a sandwich and you're sitting in the middle. Who loses here? You do. You receive a lower fee than your business requires for best business practices. The insurance takes the difference. The insurance company tells you what you can and cannot charge the patient, even as to uncovered procedures in many cases. Your treatment plan may very well be less than the best for the patient if you try to maximize insurance. Of course, the patient wants to utilize insurance only, and you want to help your patient to do that. And you get the picture. Remember, in your ethics, you serve the patient, not the insurance company. And that helps you sleep well at night, knowing that you are fulfilling your purpose to its highest cause. It's the between a patriotic soldier and a mercenary conundrum. It in fact serves your business, your family, you. This is the ethic of a leader. Again, I do not do insurance, but if you do choose to do so, the ADA CPT code is 2940, and it's called protective restoration. Let me give you the definition as published, which is direct placement of a restorative material to protect tooth and or tissue form. This procedure may be used to, and I quote, relieve pain, promote healing, or prevent further deterioration, and I would say in parentheses, including of the pulp. Not to be used for endodontic access closure or as a base or liner under a restoration. Notice the nomenclature defines 2940 as protective restoration. The current descriptor for further, it defines the intended use of the code to give you guidance for proper coding. So it is a direct restoration, let's notice that, meaning the restoration is placed by you directly onto the tooth, not fabricated outside the mouth and then placed on the tooth. And this is something in its description. And the type of restorative material is not specified. Any type of restorative material in your professional judgment may be used when the purpose of the placement is to protect the tooth and or tissue or tooth form. Tissue form protection could be filling a deep mesial fracture to keep the tissue from growing into that fractured portion of the tooth, which the IRM and the band do well. And that's one of the reasons we use the band. The descriptor then goes on to describe that the restoration may be used to relieve pain, perhaps in an emergency situation, promote healing, as in the situation where the decay may be close to the nerve pulp causing discomfort, or further deterioration of the tooth, perhaps in the instance that the tooth is badly fractured, and the restoration then is placed to prevent further fracturing of the tooth until more definitive treatment can be performed. It's also important to note that all of this descriptor I've just been reading to you makes it clear what procedures this code is not appropriate for. And again, I repeat, just so you get this point, that it's not for endo-access closure and it's not for a base or liner under a permanent restoration. So that's what we have to say about part 2 for Lori. And at this point, I close with love for you and wishes for a very happy New Year and holiday season. Savor the moments and love one another so very, very much. Good day.